second topic is to be delivered by Dr. Pankaj Shah. He is DM Endocrinology and in Mayo Clinic, USA. His area of interest is diabetes in complex clinical situation. He is going to talk on non-diabetic hypoglycemia. So over to Dr. Pankaj.
Thank you, Dr. Mayur Patel and Dr. Mona Shah for this invitation. I have been given the task of speaking about non-diabetic hypoglycemia in SwasthyaCON 2021. This is the talk layout. We'll talk about symptoms of hypoglycemia. We'll then discuss about diagnosis of hypoglycemia. And then we'll discuss differential diagnosis, which would include blood tests. And if blood tests imply there is a tumor, localization of the tumor, but not before that. We'll discuss thereafter cases, including a case of post-gastric bypass hypoglycemia. So, the symptoms of hypoglycemia. Symptoms are divided into autonomic and neurological. And autonomic symptoms are because of excess adrenaline and noradrenaline caused by release from the adrenal glands. Because of hypoglycemia, similar symptoms can happen from any reason if there is a release in adrenaline and noradrenaline. The neurological symptoms which occur because of inadequate glucose reaching brain can start from irritability, paresthesia, etc., moving on to difficulty in thinking, confusion, slurring speech, ataxia, seizures, stupor, coma, and even death. So, if there is a concern for hypoglycemia, the first question is whether the person has diabetes or does not have diabetes. And if there is diabetes, the management is simple. Treat 15 grams of glucose. In 15 minutes, repeat plasma glucose, and if it is still not okay, repeat it, etc. Thereafter, find out what caused this and prevent another episode of hypoglycemia. What about a person who does not have diabetes? That is what I am talking about. So this is a 36-year-old woman who had an episode of hypoglycemic spell in the ER. The capillary meter glucose was 36. What will be the next best step in management? We should do give her 15 grams of glucose by mouth, or 15 grams of sucrose by mouth, or 12.5 grams of intravenous dextrose, that is 1 ampoule of glucose, or any of the above is same, or none of the above. Please think about it. The right answer here, of course, is none of the above. And the reason is that, first of all, we have to make the diagnosis of hypoglycemia by documentation of Whipple's Triad, which includes symptoms of hypoglycemia, low plasma glucose, and relief of symptoms when plasma glucose is raised back to normal. So, as far as possible, if the person does not have diabetes, we should not treat but draw blood. We should draw blood to measure venous plasma glucose, beta cell peptides during the episode before treating the episode. When we draw blood, we measure plasma glucose to document Whipple's Triad. If the glucose concentration is low, we want to know if this is being caused by insulin-like action. Insulin-like action this is tested by testing beta hydroxybutyrate in blood, that is a ketone, and measuring the glucose response to injection of glucagon. Let me explain. Insulin, by its action on muscle, liver, and fat, leads on to lowering of glucose. We know that. But we also know that insulin, through its action on fat cells and its action on liver, causes a suppression of ketones. In addition, the action of insulin in liver leads on to storage of glucose in the liver as glycogen. When injection of glucagon is given, the stored glucose is released. Therefore, the glucose release after injection of glucagon and suppression of ketones are good markers of insulin action. Therefore, if beta hydroxybutyrate is suppressed, there is insulin action. If there is a robust response of glucose after injection of glucagon, there has been insulin action that has led on to hypoglycemia. If there is insulin action causing hypoglycemia, we want to know whether this is caused by insulin. So insulin should not be around when there is hypoglycemia. But if there is insulin is not suppressed, well, then insulin is causing insulin action causing hypoglycemia. If insulin is around, we want to know if insulin is being secreted. And for that, we measure C-peptide and proinsulin. Let me explain that too. This is my drawing of a beta cell. The pre-proinsulin is converted to proinsulin, which in secretory granules is converted to insulin and C-peptide. And with each molecule of insulin released in circulation, a molecule of C-peptide is released in circulation. In addition, proinsulin is also directly secreted into circulation. Therefore, proinsulin and C-peptide are good markers of insulin secretion. Insulin itself can come into circulation from injection of insulin, for example, but proinsulin and C-peptide does not come from injection. It has to come from endogenously secreted insulin. Therefore, if C-peptide and proinsulin are not suppressed, it would imply that insulin secretion, which is causing insulin-like action, which is causing hypoglycemia. If that is the case, we want to know if there is any chemical in blood that is causing release of insulin, that is sulfonylurea or meglitinides. If these are absent, then there is a spontaneous secretion of insulin causing insulin-like action and hypoglycemia. Let's discuss a few cases. First is a case of a 29-year-old woman with spells suspected to be hypoglycemia. She basically has mostly adrenergic symptoms. Her meter glucose had shown the glucose less than 40 at the time of symptoms. She underwent a supervised fast. This graph on the x-axis is capillary blood glucose, on the y-axis is the dates. About 48 hours into the fast, she had her typical spell, which is, as you note, is adrenergic. The glucose that started at about 100 milligram per deciliter before the fast started had precipitously declined. The capillary blood glucose had precipitously declined while she was having her typical symptoms. So the question for us is, what do we do now? Well, should we draw venous blood for plasma glucose? Should we draw blood for plasma glucose, insulin, C-peptide, proinsulin, hypoglycemia agent screen? Should we do all that in section B and feed patient, or inject glucagon, or proceed with 4D CT scan of the pancreas? Please think about it. Well, let me tell you what happened to this patient first. Her symptoms over the next several minutes spontaneously disappeared, and her capillary blood glucose concentration increased back and stabilized somewhere slightly more than 60 milligram per deciliter towards the end of the 72 hours. We don't only measure capillary blood glucose, but we also measure venous plasma glucose periodically in these patients. And as you can see, the plasma glucose concentration was perfectly normal, while the capillary blood glucose concentration was low. Therefore, the right answer here is, first of all, do plasma glucose. This is not hypoglycemia if plasma glucose concentration is not low, and therefore no further tests are of any merit at all. Next is a 21-year-old man with acute leukemia and a plasma glucose of 21 milligram per deciliter. This was a routine test in the morning. This patient was admitted with leukemia. The question is, what is the patient likely to have? An insulinoma in addition to leukemia, or an Addison disease, or hypopituitarism, or drug-induced hypoglycemia, or any, or none of the above? Please think about it. Actually, the glucose concentration was 23 the day before when we looked at the lab report from the previous day. Actually, the answer here is none of the above. This was incidentally drawn glucose when the patient was completely asymptomatic. So in the absence of symptoms, the patient does not have hypoglycemia. Actually, he had acute leukemoid reaction, and the white cell count was so high that the glucose was being utilized in the tube after the blood was drawn in the tube and tube was transported to the lab and measured. It is done almost instantaneously at Mayo Clinic, but even there, this white cell count was so very high that the glucose concentration declined. Actually, the capillary glucose was 85 milligram per deciliter. Therefore, we want to document Whipple's triad for diagnosis of hypoglycemia. We want to have symptoms, especially neuroglucopenic symptoms, neurological symptoms. We want to have documentation of low plasma glucose at the time of the symptoms, not capillary glucose, not glucose measured by meter, not glucose measured by a sensor, continuous glucose monitor, or the interstitial glucose, but low venous plasma glucose. And we want to see relief of symptoms when the plasma glucose concentration is raised to normal, and hopefully documentation of both of these. Therefore, when we collect blood by documentation of Whipple's triad, we can sort out if this is hypoglycemia or not hypoglycemia. Next is a 23-year-old woman who was admitted to hospital with acute pancreatitis and was receiving intravenous pain control and intravenous antibiotic while in hospital. This is what we were consulted. Plasma glucose concentration was 41. And again here, the previous day was 43. And when we asked her, she had some symptoms at the time of these low glucoses. No neurological symptoms, but at least there were some symptoms. This was associated with a non-suppressed insulin, a non-suppressed C-peptide. Beta-hydroxybutyrate was suppressed, cortisol was 18, and kidney and liver function was normal. So the question here is, what does this indicate? Does this indicate an insulinoma, a non-insulinoma pancreatigenous hypoglycemia syndrome, use of sulfonylurea? Any of the above is possible or none of the above. Just think about it. 43 glucose, insulin non-suppressed, C-peptide non-suppressed, beta-hydroxybutyrate suppressed, normal cortisol, liver and kidney function. Well, the answer here is, of course, none of the above. And the reason is that patient was sick. The patient was actually receiving moxifloxacin, and that is well known to cause hypoglycemia. The blood should never have been drawn for hormones, etc., for, I don't know, $200-300 worth of tests, because she was really sick. So if there is hypoglycemia, the next question is whether the patient is sick or not sick. And if the patient is sick, medicine history, medicine history, medicine history, and history is likely to yield more information than any further investigations. Next is a 24-year-old woman whose sister had type 1 diabetes and now has come with spells of documented low plasma glucose. She underwent a fast, and 36 hours into the fast, she had a typical spell. These are her lab numbers. Let me go through this again. Low plasma glucose, documented Whipple's triad, suppressed beta-hydroxybutyrate, a good 28-point increase in plasma glucose after injection of glucagon, implying insulin action. So insulin action causing hypoglycemia. There is insulin action, but there is no insulin. There is no insulin secretion. Well, then this is insulin-like action causing hypoglycemia, but there is no insulin. So what do I do in situation like this? I'll start looking for malignancy or measure IGF-2, and then if indicated, look for malignancy or screen for hypoglycemia agents in blood, or just discuss the case with my endocrine lab in charge, Dr. Ravinder Singh, who is in charge of endocrine laboratories in Department of Lab Medicine and Pathology at Mayo Clinic. The right answer, of course, is discuss with Dr. Singh. Let me show what happened. On the y-axis, mind you that this is logarithmic scale. Whereas the patient fasted, about time when she had typical spell, the capillary glucose went down. Not only capillary but plasma glucose went down, and it went down to 40 milligram per deciliter. When the plasma glucose was down, she had typical spells. Her insulin, beta-hydroxybutyrate concentration actually declined, implying that insulin action is causing this low glucose. However, Insulin concentration also went down at this time. Not only insulin, but proinsulin C-peptide concentration also declined at this time. So of course, I was confused. After discussing with Dr. Singh, he measured aspart insulin, bovine insulin, detamir insulin, glargine insulin, and lispro insulin, and all of these were undetectable during this time. However, when he measured glulicine insulin, there was a dramatic increase in insulin concentration at the time of typical spell. Therefore, this is insulin analog or glulicine induced hypoglycemia. So, if the patient is not sick, we want to find out there is insulin action by measuring ketone level, beta hydroxybutyrate, and glucose response to injection of glucagon. If these are imply there is no insulin action, well, then this is not hypoglycemia caused by insulin. Even starvation can cause hypoglycemia. If there is insulin action, we want to find out if there is insulin around despite hypoglycemia. If not, well, then it is not insulin. There is something like insulin that is causing insulin action, which is causing hypoglycemia. Moving over to a next 27-year-old woman who is a nurse with spells of low blood sugars and had a blood drawn during her classical episode in the morning. Let me show what happened here. Low plasma glucose, check. Insulin action, beta hydroxybutyrate suppressed, good response of glucose after injection of glucagon, so there is insulin action. So insulin action causing hypoglycemia, and there is insulin around. So now insulin is causing insulin action causing hypoglycemia. There is insulin around, but C-peptide is suppressed and proinsulin is also suppressed. Well, there is no insulin secretion, but insulin is present. Therefore, this is insulin-induced hypoglycemia, but not endogenously secreted insulin. So if there is insulin around despite hypoglycemia, that means insulin is causing insulin action causing hypoglycemia. We want to measure C-peptide and proinsulin. And if these are suppressed, it leads us to conclusion that insulin is injected and not endogenously secreted. Next is a 57-year-old woman with spells of low blood sugars, which have been documented. Low plasma glucose, check. Insulin action, check. Insulin causing insulin action, insulin secretion causing insulin action causing hypoglycemia, and therefore this is endogenously induced secreted insulin which caused hypoglycemia. What do we do in this situation? Could this be a sulfonylurea induced hypoglycemia, an insulinoma, or non-insulinoma pancreatitis hypoglycemia, or any of the above is possible? Just think about it. Low serum glucose, presence of insulin action, presence of insulin, the presence of insulin secretion. Well, of course, the right answer is any of the above would lead on to insulin secretion and therefore insulin action and therefore hypoglycemia. Actually, glimepiride was positive in blood, suggesting that this was sulfonylurea induced hypoglycemia. So, if C-peptide and proinsulin are not suppressed, causing inappropriate amount of insulin, causing insulin action, causing hypoglycemia, we measure hypoglycemia agent screen. And this, if present, it is drug-induced secretion of insulin causing hypoglycemia. Next is a 71-year-old man with episodes of confusion. Low glucose, check. Insulin action, check. Insulin secretion, check. Hypoglycemia agent screen is negative. Therefore, it is spontaneously secreted insulin causing hypoglycemia. Well, what do we do here? We now know that we have to proceed with surgery. And if you want to proceed with surgery, of course, surgeons want to know what part of pancreas has the tumor. In order to do that, we first proceed with a good quality 4D CT scan. As you can see here, the patient had tumorous growth on the pancreas, which was clipped, and patient was cured of an insulinoma and the symptoms. Next is a 44-year-old nurse practitioner who was having neurological symptoms of hypoglycemia, who was preparing for bariatric surgery, reduced calorie intake, and started having episodes of hypoglycemia. This is another example of spontaneously secreted insulin causing hypoglycemia. Low glucose, check. Insulin action from insulin being secreted, and hypoglycemia agent screen is negative. But here what happened was that CT scan was not informative. In a situation like this, we proceed with endoscopic ultrasound. Tumor is localized. Patient underwent surgical resection of the tumor as well as sleeve gastrectomy at the same sitting. Patient was cured and has over time lost substantial weight as well. Next is a 66-year-old man with essentially postprandial episodes of hypoglycemia and underwent a motor vehicle accident and had documented low glucose at that time. Underwent 72-hour fast and within a few hours of starting the fast had low glucose. So Whipple's Triad met action of insulin caused by insulin, which has been secreted as measured here in C-peptide. Hypoglycemia agent screen was negative. So now it is spontaneous endogenous insulin-induced hypoglycemia. But here both CT and the ultrasound were not informative. Therefore, in a situation like this, we do selective pancreatic arterial calcium stimulation test in which we stimulate the arteries supplying the pancreas and collect blood from the hepatic vein. Let me explain to you what is done here. We inject calcium in superior mesenteric artery, which supplies the uncinate process and part of the head. Calcium in gastroduodenal artery, which supplies the head and part of the body. And in splenic artery, which supplies the tail and part of the body. Let me show you what happened in this patient. We injected calcium in all the three arteries and collected blood from the hepatic vein. This is the baseline insulin concentration in the hepatic venous blood at 3 different time points. When calcium was injected in superior mesenteric artery, the insulin concentration in hepatic vein increased from 10 to about 20. When it was injected in hepatic artery, it went up from about 4.5 to 7.5. But when calcium was injected in splenic artery, it went from 48 to 1500, implying thereby that the area supplied by splenic artery had a lot of insulin producing cells that released a lot of insulin in response to injection of calcium. These insulin concentrations are all from hepatic vein. Of course, pancreas, the whole pancreas drains into portal vein, and therefore hepatic vein is a good site to see how much insulin is being secreted. This patient underwent distal pancreatectomy and was cured of the symptoms, and of course, distal pancreatectomy revealed the insulinoma in it. Therefore, if surgery is indicated, we want to do 4D CT, endoscopic ultrasound, calcium pancreatic stimulation test, and if none of this works, we may want to go with rotated PET scan, which has not been very helpful in our hands. The last is a 43-year-old woman who had underwent gastric bypass surgery about 4 years back, and now for last year has been having postprandial symptoms with low capillary meter glucose. She underwent a 2-hour glucose tolerance test outside somewhere where 2-hour test was 32 milligram per deciliter with high insulin, and she had some symptoms at that time. She underwent supervised fast. This is what happened. During the fast, the plasma glucose and capillary glucose concentration kept declining and stabilized itself after about 48 hours at around 60 milligram per deciliter. At the same time, beta hydroxybutyrate concentration kept increasing throughout the fast. After injection of glucagon, the glucose concentration did not increase much. It increased only by about 13 points. Therefore, elevated beta hydroxybutyrate and poor response to glucagon in terms of glucose increase suggests that there is no insulin action, leading on to lowish glucose. So this is asymptomatic low plasma glucose with no insulin action, which is essentially normal 72-hour fast. So what do? We told her that we need an urgent blood draw whenever she has classical symptoms, and she couldn't. So last day she took a donut and an alcoholic drink called mojito. And about 2 hours after that, she had her typical spills and blood was drawn. Low glucose, check. Insulin action, check. Insulin causing insulin action, and insulin secretion causing insulin action, causing hypoglycemia. Hypoglycemia agent screen was negative. So now this is hypoglycemia caused by insulin secretion after consuming fast-acting carbohydrates and alcohol after having had the gastric bypass. She underwent a mixed meal test. That is just a regular sandwich from one of our fast food joints. And as you can see, The plasma glucose concentration did decline after eating compared to the baseline, but never reached 50 milligram per deciliter. This was 60 milligram per deciliter at its lowest. She hardly had any symptoms of hypoglycemia either. Therefore, this was essentially normal mixed meal test. This is her insulin and C-peptide, but that's besides the point. Here I want to show some data from publication from Diabetologia. This is oral glucose tolerance test in women undergoing screening for gestational diabetes. And as you can see, normal women may start at 60 milligram per deciliter or even below that. And at 2 hours, there may be many women who may have glucose concentration below 60 milligram per deciliter. On the other hand, after having had gastric bypass surgery done, a lot of women have glucose concentration below 60 milligram per deciliter. Not only that, there will be several women who will have glucose concentration below 30 milligram per deciliter, and most of these women have no symptoms of hypoglycemia at that time. Therefore, oral glucose tolerance test has no role in investigation of hypoglycemia, management of hypoglycemia, diagnosis of hypoglycemia. Let me explain the physiology. The normal physiology, food goes into stomach and stays there, and then small amount of food is released into intestine gradually, and it takes about 1 hour, 1.5 hours, 2 hours for stomach to empty. This leads on to systemic appearance of glucose after eating, which causes release of insulin. Therefore, the glucose concentration which goes up quickly comes down. Sometimes it goes down below it starts the baseline. Actually, it happens most of the time if we measure glucose frequently enough. On the other hand, after gastric bypass surgery, food directly goes into the intestine, and all food goes into intestine. There is no valve. The food is not slowly released over the next half an hour to 1 hour to 2 hours, entering into small intestine. Fruit juice, the intestinal juices, of course, released from stomach and intestine, and then mix up with food in the common path. So here, the food appears into intestine, and therefore glucose appears into systemic circulation very rapidly. Actually, the amount of glucose appearing may be similar in the two situations. However, this is much more rapid and then rapidly disappearing. In response to rapid increase in glucose appearing into circulation, there is rapid secretion of insulin as well. Because of both of these, there is a dramatic increase in glucose concentration followed by dramatic decrease in glucose concentration, and therefore a postprandial episode of hypoglycemia. So, if there is gastrectomy or gastric bypass, or impaired gastric volume or capacity, vagotomy, etc., there is a rapid delivery of nutrients into the duodenum. This, because of hyperosmolar contents in duodenum and small intestine, can cause release of vasoactive substances, neurotensin, VIP, incretins, insulin, glucagon, which cause the early dumping syndrome, which are vasomotor symptoms, lightheadedness, dizziness, profuse sweating, even fainting, associated with gastrointestinal symptoms, abdominal pain, cramping, diarrhea, nausea, vomiting, and there can be hyperglycemia as well. But because of rapid absorption of glucose and no follow through of food coming after some time, the hyperinsulinemia is followed by hypoglycemia. Therefore, if there is post-meal hypoglycemia in GI surgery, we document Whipple's Triad, and we want to sort out if this is hypoglycemia or not. And if there is hypoglycemia, I want to sort out if there is insulinoma or not, as we have already discussed. If there is insulinoma, of course, we proceed with surgery. If there is no hypoglycemia, we proceed with GI consultation and then proceed with dumping management. On the other hand, if there is hypoglycemia but not caused by insulin, caused by the late dumping syndrome, we proceed with dumping management, which includes dietary changes, adding edible gums, adding short-acting somatostatin, which slows down gastric emptying as well as insulin secretion, or slows down intestinal motility as well as insulin secretion. And then if that doesn't work, we may want to give acarbose if there is hypoglycemia but not by insulinoma, and rarely diazoxide has been used to treat that, though I have never prescribed that. And if none of this work, we may want to reverse the gastric bypass or slow down the intestinal motility by surgical intervention. So if there are postprandial symptoms that are multifactorial, precipitated by refined carbs, sugar drinks, drinking water with food, eating rapidly, especially eating with fizzy drinks or drinking alcohol, the solution is to avoid the precipitants of these symptoms. Use edible gums, acarbose, somatostatin, short-acting somatostatin. And I highlighted that oral glucose tolerance test has no role in hypoglycemia. To summarize, therefore, we discussed that if there is a concern for hypoglycemia, we want to sort out if there is diabetes or not. If there is diabetes, we treat, find the cause, and prevent as far as possible. But there is no hypoglycemia, we don't want to treat, but collect blood if at all possible. Document Whipple's Triad, sort out if this is hypoglycemia or not. If there is sickness, well, we look for history. And if there is not sickness, we want to see if there is insulin action by measurement of beta hydroxybutyrate in blood and glucose response to injection of glucagon. And if that is not implied that insulin is causing it, well, then it is hypoglycemia not caused by insulin. For example, starvation can cause it. If there is insulin action, we want to measure insulin. If there is insulin around despite hypoglycemia, well, that is what is causing insulin action. If there is no insulin around, well, there is insulin-like substrate that is causing insulin action. If there is insulin, we want to know if insulin is being secreted by measuring C-peptide and proinsulin. If these are suppressed, then there is insulin injection causing insulin action causing hypoglycemia. If these are non-suppressed, well, then we want to measure sulfonylureas and meglitinides, and if these are present, then it is drug-induced insulin secretion causing insulin action causing hypoglycemia. If these are absent, we want to proceed with surgery, and before surgery, we want to do localization by 4D CT, endoscopic ultrasound, selective pancreatic arterial calcium stimulation test, and rotate PET scan if required. In addition to that, we also discussed the post-meal hypoglycemia after GI surgery. We discussed that we sort out if hypoglycemia or not, if it is insulinoma or not, and if it's not non-insulinic hypoglycemia or there is no hypoglycemia and just the symptoms of dumping syndrome, we go ahead with management of dumping, and we proceed with oral glucose tolerance test that has no role in hypoglycemia in anything, in investigation, in management, in diagnosis, anything. Thank you so very much for your patient listening.
Thank you so much, sir. It was wonderful session. It was wonderful to hear you. Now I request all the panelists to turn on their camera for the group photo. Just a minute.
It's fine. Yeah. Yes, Asha. Yes, Dr. Ila.
That was excellent. The hypoglycemia, I mean, wonderful cases and very, very interesting. Thoroughly enjoyed. So, are there any questions in the chat box? I don't see any.
He has elaborated like anything. So,
Yeah.
Dr. Pankaj, sir, it is indeed pleasure to listen from you. And thank you for being there and supporting the conference. And your talk was so elaborative. We went through the whole thing. So, pleasure, sir. If you want to share something, sir.
I just am here to thank you so much for the opportunity to present. Thank you, Dr. Patel, for this opportunity. This is very well organized meeting with great speakers. I'm enjoying it thoroughly.
He is there from his early morning and attending and participating. Thank you, sir.
Thank you.